All right. Well, thank you everyone for joining us this afternoon. My name is Lindsay. I'm the program administrator for the Center for Evidence to Practice. Many of you have participated in our EBP meetings. So thank you for attending this webinar today. We know that many of the providers across the state are transitioning, have already transitioned, and had to rapidly adapt to how to do your services over telehealth. So we're trying to offer services to providers to support you through this transition. And as many of you have seen, we also are having a webinar series specific to the EBPs that you may be trained and certified in. So I'll drop the link to our webpage in case you haven't seen it. Kelly will also be leading a 3-part series on trauma-focused CBT for telehealth. So if you're trained in TFCBT, make sure to join in on that. And regarding today's training, everyone who participates will receive a CEU certificate to your email. Apart from that, I feel like I'm missing something, but I think those are all the announcements. So Kelly has been working with us. She is a trauma-focused CBT trainer and a national consultant. And thank you. I will hand over the mic to Kelly.
All right. Welcome aboard, everybody. Do we have most people now, Lindsay? I think we do.
I think so, yes.
Let me click over here. Or let me move this. We have 65, so we're pretty good to go. Let me move back here. So, hello, everyone. I am Kelly, and I am originally from Mississippi. And you will hear that southern drawl. I grew up in Bassfield, which is about this big. We're still working on getting a stoplight. We did get awards, so that was a big thing. And I went to school at the University of Southern Mississippi in Hattiesburg. And so New Orleans, Louisiana, right there on the edge. So I kind of feel like you guys are my people. You'll see on the slide that I am currently in my office, in my basement office in Madison, Wisconsin. Basement should have given it away because we don't really have those in the South. And I've been here for 3 years. Like Lindsay said, I am a TFCBT nationally certified trainer consultant. I also train other models, a lot around child and adolescent trauma, family trauma. That's my specialty. I'm glad to be here with you today, and we're going to talk about not just doing telemental health. We're going to talk about telemental health during a pandemic. I tend to have not the most proper language. Go Saints. I tend to have not the most proper language, so Lindsay will hide her ears if I happen to say bad words. And if it offends you, just let Lindsay know. But we didn't ask to do telemental health. It just kind of slammed up on us. And we're not only putting it into place quickly, so telemental health was out there, it was kind of bubbling. We had psychiatric services and we had some remote crisis services by telemental health. And then all of a sudden, there's COVID-19 and bam, pandemic, go home, find your clients. Anybody else experience it like that? Go home, find your clients. And we know that happened a lot of places because we know that they said, okay, don't worry so much about HIPAA, just find your clients. And so we're not just doing telemental health, we're doing telemental health during a damn pandemic. And we'll talk more about that in a minute. So I am in Madison, Wisconsin. I'm a licensed independent, I'm a licensed clinical social worker. Let me say that. And I've always, let me show you. So you have to do this with the camera, but I want to show you this. And it's important, right? So kind of look, I call them the twins. It's important to notice those because I always thought that the apocalypse, you know it's going to happen. We've heard about the zombies. They're on TV. They're on the internet. We know it's coming. And after I moved to Wisconsin, even though I had this before, I moved to Wisconsin and I'm like, you know what? The zombies are going to come. I travel for a living, or I'm in Wisconsin, I got to have enough fat on me to get back to Mississippi. We get 2 seasons of tomatoes. I'm trying to make my first tomato grow up here this year. And so I was like, I need this, right? Because we all know that the apocalypse is going to look like anarchy and zombies. Folks going to be trying to eat me. They're going to be trying to get my juicy. I got to make it in Mississippi. If we can't grow it, we can kill it. We can catch it. I never expected the apocalypse to mean I had to go to my basement without toilet paper. Never thought that would be the apocalypse. Everybody fighting for the toilet paper. So what we're going to do today is we're going to look at the research a little bit and the practical applications of telehealth. We're going to look at strategies for delivering mental health services. And we're going to just take a minute to remember that we're all in this together. Nobody's doing this alone. There are not experts out there poised to tell you how to do this. There are people who have transitioned to telemental health already, but there's not like, we know exactly how to do this in Louisiana. We know exactly how to do this from Felicia's house. We know exactly how to do this from Rosina's house. There's nobody out there that's going to help you with that. So usually if we had taken this on, we would do it agency-wide and would be a phased-in process. Hey guys, we're going to do telemental health. Hey guys, we're getting you computers with cameras. Hey guys, there's going to be a training. And then, hey, we're going to launch telemental health with a few clients when we get it right with everybody. We didn't get that luxury. It was like, go home, figure out Zoom. Oh, yeah. So there has been a lot of research supporting telemental health. Hilty and Goff, the two people cited first, have done a lot of the research if you care to read it. And what they found is that telemental health really is effective across populations and disorders. They found it effective for adults and children. And then Gloff and Stewart said it's effective across racial and ethnic groups. So it's been researched. It's been researched with multiple populations around the world. A lot of it has been kind of frontier work in our areas are areas where kids and families can't access mental health easily because of transportation, because of money. So there's been that happening. And what we know is the biggest barrier is, one, technology. Does the client have the technology? And two, a sense of, can I actually do this? And if a client is like, I don't know how to work a computer, I don't know how to put an app on my phone, our job then is to be there and help them do that. Make it easy. First session, whatever session, we need to be prepared to walk them through, how do you actually get on the platform I'm using? How many of you guys are using Zoom?
I'm using Zoom. We also do FaceTime, Google Duo. I work for an ACT team.
Valerie, you doing everything. Pretty much
It looks like it.
Pipe them in. What's that?
We're even just doing it via phone without video. I work for an ACT team.
What does that mean?
Just calling them on the phone and calling them on the phone and just doing phone sessions without using a camera or anything like that if they don't have access to a camera.
And what is an ACT team?
Assertive community treatment.
Okay.
It's like around service. We have, like, on the team, there's a housing specialist, employment specialist, substance abuse specialist, nurses, peer support, team lead,
Gotcha.
and program assistant.
It's mental health rehabilitation.
No, we're different from an MHR.
It's wraparound.
Yeah, we're different from an MHR.
And so you usually have a lot of contact with the client. Your wraparound is pretty intense.
Yes, ma'am.
All right. So thank you for being out there and finding people however you can.
That's what they expect us to do.
Thinking more about research, got a lot of people who use Zoom and Doxy. WhatsApp, we got other things over here. Somebody uses Simple Practice. I have Simple Practice. I use Zoom for my meetings. But it's also been found, research specifically in the United States, with high success globally. And what Barsher found was that telemental health is as effective as in-person treatment. Now, that doesn't mean for everybody, and in-person treatment's not effective for everybody. And what we're finding as this is coming out is some people really respond to telehealth, and some people really say, I can't do this, it doesn't feel right, it doesn't feel real. The other thing that's really emerging is that if the therapist, case manager, support person, whoever, if the person initiating the meeting is confident and appears comfortable, then the person on the other side is more likely to have a positive experience. If we lead off a meeting with, I don't like this either, then we kind of set up the setting for, well, I don't like it either on the other side, right? But if we lead with confidence and some competence, I always think of what makes a really good provider, what makes a really good partner with other people in mental health. So, and it's competent, you have to know what you're doing. And it's confident, you have to feel like, yeah, I know what I'm doing, or at least come across that way. Sometimes we fake it till we make it. And then it's comfortable. Do you appear comfortable on the screen? And that's the same with any treatment we offer in person. You want to be competent, confident, and comfortable. And then you've really mastered it. All right. Research supporting telemental health from the American Psychological Association said that the standard of care is the same as in-person treatment. And that's a randomized controlled trial. So the standard of care is the same as in-person treatment if the clinician or whoever is as good as they are in person. So another thing to really take to heart early is you are the same person on a camera as you are in person. Nothing's changed. Nothing's changed about your knowledge base, your skill base. I hear from clinicians across the country, I don't know if I can do this. And the answer is yes, you can. You can do this. It takes some creativity. It takes some new learning. It takes some getting used to, because where we are usually automatic in how we approach somebody, now we have to have some technology in between. But you're the same clinician that you were in February. It's just a matter of making it work in this platform. So bottom line, come back here. Telemental health is a effective way to do treatment. We do have to consider privacy issues and HIPAA right now while we're in the pandemic. HIPAA has been really softened all around. I think that we've done this and they don't know when it's going to end or if it will happen again. HIPAA guidelines are going to have to figure themselves out because everybody can't afford the high dollar HIPAA platforms. DoxyMe is HIPAA compliant, but it doesn't allow an interactive screen. So it has its ups and downs. And then we're also going to have to think about agency budgets and stuff and how do we get really secure platforms going. We're going to talk mostly about Zoom today because that's what I use. And if somebody's a DoxyMe or another app user, if you'll help us with that one, that'd be great. So when we think about HIPAA, what are you doing during the sessions? That's one thing for HIPAA. What are we doing? And we always, where are we doing it? We always you know, look at privacy. We look at confidentiality. We have white noise in our office sometimes. We make sure the door's closed. We do all of those things. Where are you doing your session? Is it in a space, if it's in your house, where you can close the door? Is it in a space where you can close the door? Where is the client and our family that you're working with? One right off the bat, one of the groups I consult with said, okay, Kelly, here's one for you. I had my meeting set up and the lady I'm working with joined the meeting, and it was pretty obvious that from here down, she had a blanket, and from here down, I don't think there was anything on because her shoulders were bare. So I think she was naked from the blanket down. And I said, well, what did you do? And she said, I told her, we all have to be dressed for therapy. And I said, that's exactly right. And she said, and then this hand reached out and waved. And I heard a voice say, hey. I said, and we also have to be alone for therapy. And that's exactly right. But we can't expect people to know that. We can't expect them to know that right off the bat, right? We teach people how to be good therapy clients. Have to remember that we train people to be good therapy clients. And so getting them in a setting is part of what we do. Just like helping them to relax in our office and helping them to feel comfortable and secure in our office. And then we start with teaching and then allowing a place where they can open up. So we have to teach them how to be good therapy clients. That way what we found with telemental health is that it is the enemy of chit-chat therapy. Chit-chat therapy, how are you doing? What's been going on in your week? How are your kids? Chit-chat therapy is when the session looks a lot like a visit. Telemental health has proven to be really hard for that because you run out of material during the course of the session. It's a very, it's an intense session, and we're all sitting right here looking at each other. And so as we do that, we have to be prepared for the session. Are there interruptions? Is the technology glitchy, and is everyone wearing pants? These are your basic things to consider. You guys are going to get these slides. I'll send them to Lindsay right after this. She'll ship them out. I'm sorry you didn't get them ahead of time. That's on me. So what should I do if I only can have phone contact? Well, what we're doing with everybody right now, because this is a disaster, it's a natural disaster. How many of you, if you don't mind sharing, have been triggered back to Katrina? How many of your clients, and nobody raised their hand but Kelly, I have. How many of your clients have been triggered back? Y'all finding that? And are you asking that? Because what this is doing is leading to a low to moderate level of stress 24/7 for everybody. And with that stress, there's a sense of things being out of control. And when we don't have control, we try to find different ways to do that. So we want to do psychological first aid. Psychological first aid are the basic needs being met. Is Maslow's bottom rung being met? And if a person doesn't have their basic needs semi-secure, it's hard to focus on therapy. If our back brain, our fight, flight, freeze, collapse, our amygdala is buzzing at too high of a level, then it's hard to access problem-solving skills in the front brain. So we want to start with psychological first aid. Another part of psychological first aid is making sure people are getting accurate information, adequate information, but not overwhelming themselves with information. And that's the same for us. Chit-chat therapy would be we spend the whole hour talking about COVID-19. Therapy is we spend time talking about the impact of COVID-19 on that particular person and family. Any stabilization that needs to be done. We work on that. We can. Our job as a therapist is also to hold in the therapy session a window of tolerance. The window of tolerance being here in the middle, people are functioning at a pretty low SUD scale, pretty low subjective units of distress scale. Toward the top, we're looking toward hyperarousal, that really getting anxious, moving toward fight, flight. At the bottom underneath is hypoarousal. And that's where we're looking at the freeze collapse, the kind of reptilian brain response, where the person's just kind of given up. We want to look at stabilization too. Can they attend in session within the window of tolerance? And we want to shore up their coping skills. Any coping skills you were working with the client before the pandemic, you want to bring those back. And then you want to be assessing for, are there new behaviors, new symptoms, old symptoms that have returned, are symptoms that have been exacerbated or are greatly increased. So we want to pay attention to that. Psychological first aid and stabilization, both. Another piece of emerging information from this whole study of the pandemic has been sleep. It's one of the things that's becoming most disturbed. And people need sleep to be able to engage in problem solving, to be able to engage in joy, and to be able to handle stress. And so we're seeing a lot of parents. I had a woman I worked with yesterday, I did an intake with, and I asked her about her sleep. And she works 7 on, 7 off at a nursing home, 9 p.m. till 7 a.m. Her kids are home from school now. Her husband leaves for work at 7:30, and he gets home at 5:30. So during the day, she's the only one there with her kids, and they're not in school. So she said, I probably get maybe 3 hours of sleep at most, and it's usually broken up, except for every other week. I'm like, well, that's the first thing we have to work on. You have to get enough sleep. No wonder you're frazzled and chain smoking cigarettes. And she said, well, I chain smoked beforehand. I said, well, then let's look at frazzled. So sleep is a big thing, and eating is another big thing. Something we have to do as clinicians that we're going to learn from our case managers, we're going to learn from our wraparound support people, is knowing what resources are out there, especially around food. If we don't know that we have food for dinner, I could give a shit about my kid's behavior problem. If I don't know what I have for dinner, please don't ask me to not be depressed or anxious. So I showed y'all my belly. It's pretty important I know what I'm having for dinner. In fact, one of my first questions when I wake up is to my partner, what do you want for dinner tonight? If a person doesn't have food, it's going to be hard to do anything else. So we have to know our resources more than we did, or as much as we did for some of us. But we have to be a part of that wraparound team that I think it was Valerie was talking about. And everybody's having everybody in mental health is having to know resources for anybody we come in contact with. It's just a different time. It's not the same ball game. So we want to go back to CBT. CBT can be done over the telephone. It's been proven effective over the telephone. Some of the early research was around postpartum mothers with postpartum depression, and it was proven to be effective there. So thinking about CBT, which is really, I was looking at the evidence-based practices that are going to be covered, Lindsay, and CBT is the basis of all of them. No matter what kind of therapy you do, coping skills are going to be coping skills. There may be different ways of trauma processing. There may be different focuses within the model. But if we know our CBT, that's great. And we want to do it on ourselves too. If you're sitting on this phone and you tell me, I'm absolutely fine, things are great, I have no worries whatsoever, I'm going to worry a lot about you, at least until the webinar's over, maybe 30 minutes after. But I'm going to worry a lot about you because we're all sitting in that stress. And then parenting skills and support. And right now, even if your client's not attached to a kid, but has a kid, we're all looking at parenting skills and support. How many of you guys are homeschooling? Or how many of you were homeschooling and then now you're not anymore? Yep. I have a nephew who's a teacher and a football coach. His wife is an English teacher, mind you. He has a stepson. She has a son who's 9 years old. They call me up and they say, I don't know what to do with this kid. This homeschooling's killing me. I'm like, dude, it's a 2 teacher to 1 kid ratio. And my nephew was like, I want to kill him. I know I can't kill him because you're a children's therapist and they'd look real bad on you. I'm like, dude, don't worry about me. You ain't cut out for jail. Plus, I think you kind of like the kid most times when you're not trying to get him to do schoolwork. So I told him, stop with the schoolwork. You know what? That's a teacher's job. The teacher will catch it up in the fall if we go back to school in the fall. Nobody's going to fail unless they were failing miserably before they left school. They have to figure this out for everybody. So don't make, and this is just Kelly now, don't take, this is just a webinar, I ain't your supervisor, but let go of school. You know, maybe do the fun parts, but let's don't all lose it over trying to do homeschooling. All right, so a lot of it is our mindset. Oh, go back. And I don't know how you can see this, but some days I am Pooh on the left side of the screen walking down the woods. What day is it? Asked Pooh. It's today, squeaked Piglet. My favorite day, said Pooh. And I'm right there. My coping skills are on board. I'm doing it. I got it going on. I can see the sunshine. Some days, or sometimes of every day, it's like the right side of my screen during the pandemic, where they're sitting on a log and Pooh says, what day is today? And Piglet squeaks, it's the day we burned this motherfucker to the ground. My favorite day, said Pooh. I don't know about you guys, but I go up and down with COVID. I'm primarily stable, primarily using my coping skills, but sometimes there's just like, I wish I had a fucking blowtorch. And my partner's like, what would you burn down, our house? I'm like, no, I just stand in the front yard and burn down COVID. I don't know what I'd burn down. I just want a blowtorch. Needless to say, I'm never going to get one. All right. Another thing for us to consider is you are on the front lines of this war. All of this comes back to telemental health because it all puts you back to where you are when you click on that screen. You are on the front lines of this war. We're not in the hospitals. We're not in the emergency rooms. We're not out there doing that, but we're holding the mental health front, which is extremely important because people who are stressed, anxious, out of control, people who lose the ability to stay grounded in the moment and then do stupid things or not helpful things. I want a therapy word, not helpful things. They're way more at risk. Same thing for us. We're on the front lines of this war. And that's been proven through lots of different disasters and crises, that if we don't take care of the mental health, we're going to lose the battle around physical health. And so I want you guys to really think about that. And part of that is, like Dr. Martin Luther King Jr. said, whatever affects one directly affects all indirectly. We're not in the emergency room. We're not on the ICUs, but those folks get interviewed every night and every day, and we hear it. And we have to decide how much we hear it. Whatever affects one directly ripples out to everybody. So if your client has a close relative or friend who has COVID and is in the hospital or has passed away, that comes to your client, and they're holding that when they come to you. And then they pass some of that on to you, because we hold their grief, we hold their anxiety, we hold during that time in the room. And we also carry some with us when they turn the camera off. And you have to look at how much of a load are you carrying. We can't take on everybody's stuff. You have to look at what's going on in your own life. Now is a really good time to do the Professional Quality of Life Scale. It's free on the internet. It's called the ProQL, Professional Quality of Life Scale. It helps us look at burnout, secondary traumatic stress, and satisfaction. Personal stress and satisfaction. So I really encourage you. We start with self-assessment. Say it one more time, the Professional Quality of Life Scale. So, stop. Is your client experiencing an emergency? Is it an emergency, or does it feel like an emergency? Are they always in an emergency? Was your client prone to emergency status before COVID-19? So, are they in an emergency? Do you have to respond right then, right there? One thing with telehealth that's happened is, because we're in our homes and they're in their homes, it feels more like they can contact us more often. Not for everybody, but for some people. You know, it gets a little more casual than if we were in the office and holding those boundaries. So what do people need? They need psychological first aid. You can find that training just by typing in psychological first aid. You can find it easily on the National Child Traumatic Stress Network. So it's nctsn.org. And you just type in the search bar, psychological first aid. That's what we need for an emergency during a crisis. Transportation issues, parents being at home with their kids, needing to get to the grocery store. We can only do so much there, and we can only hold so much of that. Any of you shopping for your family? You go out and do the shopping, take it to your mom, your dad, or your elderly cousins or immune compromised folks? Yeah, we can't hold everybody's how do I get to the grocery store. We can help them problem solve. But if we start doing things for them that they can learn to do for themselves, we're not empowering them to do it. So some of us may be feeling the need to go out of our lane and do extra things for our clients that we might not have done before. Like maybe just this one client, I can go to their house, or I could drop stuff off on the porch. You have to save your resources. You have to save your attention where it matters most. And that's in your home. So I'm not telling you to do bad therapy. I'm telling you not to become overwhelmed trying to save everybody. I especially say this to you guys and my Mississippi people, because we've been through things where it's felt like I need to be out there, I need to be helping, I need to be doing something. And there's some things we can't do, that it's better to let somebody else do, or we can't feed everybody. I was on the phone with a group of clinicians the other day, and one said she had lost her husband suddenly a year and a half ago. And so she was all alone in her house, and she wasn't coping well. She said the loneliness, the grief, there were new areas she hadn't even thought were there. And I said, well, how are you dealing with that? She says, I cook. I said, okay, that's cool, but you're in your house alone. She goes, yeah, I smoke like 6 racks of ribs, and I just take them to needy families. I said, you take them how? Well, I take them to their porch. I don't go inside. We just stand, I stand on the steps and we talk through the door. And I'm like, okay, let's think about that a minute. So how do we balance everything? How do we balance everything? How do you balance being a mom or a dad with kids at home, with partners who may have lost jobs, or you guys have lost income, I don't know, with all the news we see and just the tension and the feeling in the world today, with our clients' needs? How do you balance everything? Where do you put energy? Where do you put resources, and at what time? Now, if we think about the impact on clients, if everything is trauma, nothing is trauma. It's like the #1 trauma principle out there. If everything is trauma, nothing is trauma. So if we're engaging in telemental health and we're treating every session as though it's, the person is being routinely traumatized. If we have somebody who's living in chronic trauma, we have to make a report. So if everything's trauma, nothing's trauma. And that's for us too. We have to think, where do we have control? Like I mentioned earlier, the thing that I'm seeing play out the most is that lack of sense of control. So where is trauma? Is past trauma getting triggered? Are they experiencing a trauma? Are they experiencing someone in the hospital, loss of somebody? And with kids especially, what are they hearing and how do they see the adults handling that? And here's where we come to, we need to anticipate the second wave. So with the pandemic and telemental health, kids aren't going to school, churches aren't in session, or churches aren't having services. Religious activities have been put on hold because we can't have crowds. And we are going into houses by camera, and we might be the only mandated reporter eyes that see that kid up close, or see that spouse or partner up close when we think about domestic violence, intimate partner violence. So we have to think about, we're not out of the woods for making reports. And we have to hold that probably, or not always, not probably, don't say probably, Kelly, but sometimes there's nothing going to happen even though we made that report. So we're going to be in people's houses. You may have already been an in-home therapist, but if you're an office-based therapist or a school-based therapist, we're going into people's houses. And we have to know that for a lot of reasons, but we have to think about, what is the second wave? And the second wave is, we know there's going to be an increase in domestic violence. We know there's going to be an increase in child abuse, sexual abuse, physical abuse, emotional abuse. We know that there is a direct correlation from unemployment going up and the use of opioids going up. The recession showed that when families, the unemployment rises, drug use rises. I found it particularly enlightening when they started closing down everything, but liquor stores up here were considered essential services. And then it was, how fast can we get to-go cups from restaurants? Because it's a coping skill for a lot of people. So if we have people on our caseload, or adults on our caseload for kids who have struggled with drug and alcohol issues, we have to be checking for, are they going back there? I was doing one of these webinars just like this, lots of people showing their faces, and one of the participants picks up a drink, and everything in me said, that's Miller Lite. I grew up on Miller Lite. I know that can. So it's like 2:30 in the afternoon, and the clinician learning how to do telehealth is popping a Miller Lite. I'm like, well, that ain't horrible, or is it? But don't need to do that during their sessions. Let's just don't do it during our sessions. So we have to ask people questions. We have to ask direct questions. How are you dealing with this? Have you returned to? Are there any unhealthy coping strategies that are coming back up? What is your stress level, your anxiety level? But we also have to not assume that that's the, that it's really a stressor for them. Some people are doing okay in this. And with them, we want to return back to treatment as usual. But looking at knowing that there's going to be these spikes and knowing we're the only mandated reporter eyes, or sometimes the only ones that are going there, mitigating factors of having relatives come through or friends come through have been interrupted. Things that can help change a day around have been interrupted. Spouses are around each other more. Maybe. I know I travel for a living training, doing trainings all over the country, and I have never been with my spouse this long for a period of time. And I'm kind of at the point of, if you tell me to turn the lights off one more time, we turn the lights off, I'm not cooking dinner and you don't cook. No more dinner. Every time you say, did you turn the light off? Taking away a part of your plate. We're going to have corn on the cob? Nope. 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 We're down to just down to a burger now. You don't want to lose the bread. So it's great and wonderful that we're together, but it can get a little trying when you can't have space. We know there'll be an increase in separations and divorces. So we want to check on all of these things. And we want to really take advantage of the tele part of the mental health, because we can see people. And we know that in therapy, we assess people a lot by how are they looking. How did they look? How did they look? Were they disheveled? Did they seem to be dressed appropriately? Were they wringing their hands? And so what makes telehealth work a lot is that we can still see affect. One thing I'm worried about is that as people start going back to the offices, if we have to wear a mask, it's hard to do. It's really hard to read affect and do therapy if all we can see is the eyes, because we learn how to co-regulate and stay in that window of tolerance by watching their nonverbals. We watch those nonverbals. And for me, I would much rather be doing it this way than behind a mask. All right. We have to know that all behavior is an attempt to meet a need and therefore has meaning. All behavior is an attempt to meet a need and therefore has meaning. And whatever a person does to survive an overwhelming circumstance, if it is trauma or whatever, is brilliant in the moment. A lot of times after that, it's kind of screwed up, but it's brilliant in the moment. So asking about social health, I wish they had never called it social distancing. I wish they had started with physical distancing, but thinking about how can you engage them via telehealth to look at what are their emotional and social supports. How many of you work with teenagers? How many of them have lost their phones during this? That's just mind-bending to me. Control of the phone. You got to turn it in at 9 o'clock or even 8 o'clock or whatever earlier. But teenagers are social creatures. And they do better when they have contact with other teenagers. Not all other teenagers, but some other teenagers. And so even thinking about the parenting work we're doing, how do we help people stay connected? As well as how do we help them feel connected to us via this platform? All coping strategy, all behavior is an attempt to meet a need and is a coping strategy that works while it works. I am going for roly-poly. Somebody gave me a box of Girl Scout cookies. It wasn't even the kind I like, and I'd be damned at the end of the week, they were gone. I looked at my wife, I said, hey, did you eat all the cookies? And she's like, I haven't had one. I'm like, oh. I'm the only other person in this house. Wait a minute. I ate up all the cookies. Chocolate can't come near, and I swear I need ice cream every night. If I'm going to make it through this thing, it's either going to be beer or ice cream. Pick my demon. So Anything we do is an attempt to meet a need. Trauma is chaos, structure is healing. Our sessions on telehealth have to have structure. We may be one of the only things that feel structured in their whole world. So we have to have a beginning, a middle, and an end. And that might be where we place, are we going to save COVID for the end or the beginning? How do we do a check-in to see if that needs to be part of today's session at all? Sessions need to be private. Sessions need to be work and not just visiting. I talked about chit-chat therapy. And they have to be engaging. And here's where we come to what kind of technology platform are we using? Is it one that we can engage people with? Can you share your screen? So if I were going to keep you engaged, I would have earlier done this, not showing you my email, but if I were working to keep you engaged more, which I should be, I would have taken you to nctsn.org if you were my client. Take you there while we're together. I can't spell. And I would have shown you how to get to psychological first aid. I would also, if you were my client, take you to NCTSN because I can't give you a handout, right? Take you to NCTSN and I would do COVID and I would show you resources. So if I had a person who was dealing with a kid with traumatic separation, there's a lot of traumatic separation right now, kids in foster care, not being able to see biological family at all, being separated from grandparents, parents who are in the hospital and they're separated from everybody. Maybe a mom or a dad is in the hospital and the kids can't go near them and we don't know what's going on with them. And we're hearing adults say it's bad. So I would go here and go over this handout with the caregiver. If I wanted to look at how to build community circle and maybe talk about some ways to really increase social time and emotional connection, I might go here. If I needed it in Spanish, I got it here. Parent caregiver guide. And then simple activities for children and adolescents. There's lots of things on here. Fighting the big virus, Drinkin Sam's questions about the disease for little kids. And there's 2 whole pages of them. So part of keeping people engaged is having the screen change. It's a huge engagement technique. Is how do we keep the screen changing? We have to keep their picture up so we know how they're responding to it. But how do we keep things moving on the screen? Not constantly, but enough that we draw their attention. Right. So we want to be engaging. We want to back and forth. Remember that close-ended questions, yes or no questions, are also an enemy in therapy. Open-ended questions. Remind yourself, open-ended questions. If I have somebody who's uncomfortable on the other side, and I say, do you ever? I'm going to get a yes or a no. Some people might expound upon that, but if I don't want to be here, I'm going to give you a yes or a no. And that's the same as in the office. They need to adhere to whatever structure you've already set up. So they need to go back to the treatment plan. What is the treatment plan? If you have it available and you can pull it up, that's great and wonderful. If not, typing out what we know on a Word document. So these are our goals. Let's look at the strategies we're using for each one. So in game at the end for kids is really good. Having them build a virtual folder for some of our people with resources, helping them on their computer or their tablet. Harder on a telephone, but can be done through Dropbox. They can build a folder that has their resources in it that they can go to when they want to look at relaxation, affect reg, whatever. And then we want to think about our liability and ethics. You can purchase for yourself an addendum to your insurance policy, your liability policy, that's specific for telehealth. I went on and did that. My license is, my insurance is through NASW. And I went and added, and I think it was maybe $80 or 100, I can't remember. But I'm in private practice, and so that was very well worth it. Because we can't control everything. We can control our environment to some degree. If we have kids at home, not totally. I have a cat. You can't control a damn cat. That thing is going to walk across the screen. Lindsay's probably seen it before. It comes across the screen, But kids running in to say, hey, mom, or hey, dad, can I get this? Can I get the other? Siblings walking in. I had one kid who put the clinician in the drawer. She was talking to the clinician on the iPad. The sister broke into the room. She said, I'll be right back. She put the iPad in a dresser drawer. Clinician could hear her having an all-out fight with the sister. Heard the mom come separate them, which mom did a good job. She got to hear some natural parenting in place. Comes back and says, where did I go? And she said, oh, I put you in the drawer. And it was my underwear drawer. Yeah, we don't usually see people's panties. That's okay. Had my own client, younger child, about 6, try to take me to the bathroom with him. I'm like, wait, where are we? Oh, the bathroom, I gotta pee. No, you have to put me outside the door, close the door, and wash your hands. Even though I can't touch you, wash your hands. So we can't control what's going on in their world, and it's worth us having a rider on our insurance policy that says we can't control that. Also, can things be overheard or interrupted by a third party? And this is where HIPAA is really big, because if it's an insecure platform, others can tap into it. You guys heard of Zoom bombers? You put people out of school and out of work, and you leave them at home, and what do we spend our day doing? Trying to figure out how to bomb into other people's meetings. Yeah, something to do, man. So as professionals, we want to be in a room that has a door. One thing that signals confidentiality in our office is when the client comes in and we close the door. It can be very helpful if the client sees you have a door. So if they can see behind you, or if you say, I'm going to close the door, and they hear it close. Just that little bit can improve the sense of confidentiality, the sense of privacy. So even if you sign on and you say, I'm going to close the door, and then after another session, maybe you say, I have already closed the door. But if you have somebody who's worried about confidentiality, that's a good thing. Want to make sure you have a neutral background. We don't always think about what's behind us. I had a clinician who on the camera while we were doing a session, well, not a session, we were doing supervision, had behind her, it was beautiful, but it was definitely a wine rack. Definitely had a lot of wine on it. And I thought, now, what if I were a recovering alcoholic? And I'm stressed, and you're moving me to a vulnerable place. I might only focus on that wine rack. If we have crosses or a cross behind us, what if our client is not religious? What if our client is an atheist or agnostic? What if they've been hurt by the church or their church or whatever? So we want to make sure we have a neutral background. You want to make sure you don't have a lot of your family on the wall behind you if you don't want them seeing your family. And that would also be distracting. So you can do the screen behind you where you put the screen on through the computer. My computer doesn't support it. It's a little old, but we know that Charles is in Paris. Right, Charles? Yeah. And so that's a way you might solve the problem. Kind of be like on the news where everybody's in New York with the same background. And we know they're just pulling that up behind them on the screen. We want to remove audible distractions. So we may have our own kids or people at home with us. And if you're working with a teenager or a kid and they can hear your child's video games in the background, you ain't getting nothing. You have lost everything. If you're working at your house and there's other people, letting them know that you're going into session can be really good. I was doing a consultation call with a group, and one woman said there was just this racket in the background, racket. And she said, hold on. She put me on mute. She left. She came back, and I said, were your kids okay? She goes, girl, that wasn't my kids. That was my mama. I can't get her to shut up. We're all stuck in here together, me and another grown sister and my mama, 3 grown-ups in the house, and mama won't shut up. She said, it is driving us crazy. I'm like, okay, well, take care of mama. I want to help mama, have something to do during this time. The other thing is, and very few of you are on camera, but look at yourself on the camera right now. What do you see behind you? Do you have a plant growing out of the back of your head? Is there enough light that they can see your face? Therapy works. Telemental health therapy works because it's synchronous. We're in real time, and they can see our reaction to what they say as well as we can see theirs. So if you pop yourself on the screen, and what do we see behind us? Is the lighting good enough that they can see our affect? There you are, Gina Lewis. Sometimes you're orange, sometimes you're back. Hey, Valerie. Hey, Rachel. So, and Bertha. Alexis. Leanna. What do you see behind you? That's important. And the lighting is something that I'm finding to be most problematic. Hey, Phyllis. Because if your lighting is dim, I have a little lamp that's hooked to my computer, and I put it over here so they can see me. If there's a big glare, they can't see you. And we want to do the same with them. Make sure they have adequate lighting so we can see them. We want to make sure our equipment is good to go. Always have your charger available. Always have your charger available. You never know when you're going to look up and the battery's going to be flashing. So you want to have your computer, your laptop, your tablet, your phone, whatever you're using. You want to have your charging cable nearby. That's not battery, but charging cable. A headset, even if it's just the sets that come with your phone that you put in your ear, one helps you hear them better, but it ensures confidentiality for what they're saying because it doesn't go past here. And they may also want to use headphones so anybody in their house doesn't hear what we're saying. If what we're using has a chat box and they really want to tell me something, they can go to their chat box. We want to encourage them to use it. I got to get mine back to everybody. This is one I got the other day. Kid didn't want to say it out loud, but was willing to type it in the chat box. My mom and dad have been fighting a lot lately. So it gave me a way to ask some questions. And I knew that she was going to be nervous about saying anything over the phone. But I could ask questions and she could answer back. She had her headphones on. Some was nodding. Have they hit each other? Have they thrown anything? Have they threatened each other? So had to do a bit of an assessment there. Your teens like to use, Marty said, my teens like to use the chat feature a lot. Yeah, they chat all the time. They text all the time. It's just like the way they communicate. We want to make sure that we're confident sharing our screen, our whiteboard, or whatever. If you're using Zoom, you can share a whiteboard. Oh, come on, share that whiteboard. You can share a whiteboard. And if you guys look where, I think it's by your name, where there's 3 dots. You see 3 dots by your name? You have something that says more options or more. It's somewhere on your little picture. And you'll find annotate, ANNOTATE. Allows me to write something if I want my client to see it. I'm getting better at writing. Oh, not too much better. But if you find your annotate, anybody found it? All right, Lindsay, help us out. So if you go to your picture, is there 3 little dots beside it? Okay, your bar, let me try that. Your little black bar that floats on the top or bottom of your screen, you see that? That's where it is actually. Go to more options. Sorry about the 3 dot thing. See on the bar where it says more? And there we go, look at there. And so you can write on my screen. This allows us to go back and forth. If I have a client who is starting to check out on me or dissociate, I might go over here. And who drew the little person? Who's writing on my screen? You doing it, Shirley? I want you to follow I'm going to put, this is something I found particularly helpful. I'm going to put a star, and I want you to follow the stars. Draw a line to the stars. And see how I brought Shirley, she has to be right here with me. So if somebody's starting to drift, starting to dissociate, check out, follow the stars. Draw me a sun and a moon. You can just ask them, even during a session, to just draw something for you. And it brings them back into focus. And then as the host of the meeting, you can erase anything. So I can erase that. Another thing I can do is I can go to and some of you may already be doing this, but I can go to YouTube. And some of the books we use with kids are on here. I think Trinka and Sam and the Big Virus are on here. But if I take out my headphones, where are they? Keep going, lady. Can you hear her? Yeah, she's not my favorite one. That's just the first one I popped on. But if you want to do relaxation scripts with somebody, or you want to do anything else, you can just pop it into YouTube. You can also show apps if you have apps on your thing like Calm or whatever. So you can just put any of these on. If a kid likes to talk and has a big interest in music, they can play it on a speaker and you can hear it, and y'all can talk about the music, or an adult.
Serving these counties. Call us today.
Skip you. So we want to keep it interactive. And if we're going to use a resource, pull it up on the screen and show them. All right. So I'm going to erase all of you guys. We're all drawings. Look at you. Look at you. Sneaky people. Somebody's just getting me. All right. Where did my slides go, Lindsay? What'd you do with my slides? There they are. Y'all notice everything is Lindsay's fault. us being familiar with the platform, and do we have enough bandwidth? So this might be a time you ask if your kids are all on devices that they come off the internet if you need to. Otherwise, you'll come across garbled. And remember that you can turn off even the Wi-Fi connection on your phone if you need a little more bandwidth. But what's running on the internet? Some of us have internet that's fine and can handle a lot of devices. Some might be sketchy. We have to remember that right now, I think there was a 136% increase in Zoom users, something like that. It was huge. So if I had done anything, if I could go back and do anything, well, there's probably a million things, but one thing I would do is I would have sunk some money into Zoom. I would have bought me up some Zoom stock, man. But we have to remember a lot of people are using the internet now. Kids are going to school by it all throughout the day. A lot of work is happening this way. Anybody had a family meeting this way? Or did anybody had cocktails by Zoom? I tried to play games by Zoom, but that didn't work. Cocktails was much better. My whole family really liked that one. All right, professionalism. You can work at home, but you cannot be at home and work.
Hey, Kelly, can you reshare your slides?
Oh, I can. Did I lose them when I still have the whiteboard? Yeah, got to be familiar with your technology. So you can work at home, but you can't be at home and work. We need to be sitting up straight, or at least sitting as straight as we sit. We need to be focused. We need to be present. Therapy is all about presence. Are we there in that moment with that person? This is treatment work, not visiting. We need to be dressed appropriately. If you wouldn't wear it to the office, don't wear it on the camera. Just easy. If you wouldn't wear it to the office, don't wear it on the camera. If we look disheveled, if we look a mess, we're not going to really send a message of confidence. It's really, you know, you in your pajamas, got your head thing on. I would have my bandana on because my hair has done nothing but grown and lost its color. But if we're sitting there looking a hot mess, we're not going to instill confidence. We want to do all of these things also because we're mirroring this for them. Routine is an important part. Structure is healing. We want our people, if we, not every day, but most days, getting up, getting dressed, going, doing some normal things in their day, even if they're not leaving home. I saw where clothing sales have drastically been dropped, but pajama pants is way high. And they were talking about in Zoom, you can, or on telehealth or whatever, telemeetings, you can wear a nice shirt, but nobody knows what you have on the bottom. That's well and good unless you have to get up. Anybody see the thing where the news anchor was wearing shorts? Yeah, you have to get up, right? And if you're working with kids or little people, or even, do this real quick, or even adults, another way to engage is to stand up and have them stand up and stretch, right? If we want to do, everybody stretch your arms up. Everybody come on, stretch your arms up and push and push and push the sky real high and let them fall and be a windmill. And then up and push, 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 and let them fall and be a windmill. All right, now roll those shoulders, roll those shoulders. The shoulders and the neck during telehealth are catching hell. Anybody feel their shoulders and necks griping at them at the end of the day? And the other thing is our eyeballs, looking at this blue light a lot. A small camera, webcam, which are sold out a lot of places, but a webcam allows you to have a wider view behind you and a sharper picture if you do back up. Anybody work with young children, 7 and under? You're gonna have to be able to stand up and jump around. You would stand up, move in your office. You want to be able to do everything that you did in your office right here. There's lots of games and videos and stuff on the camera that you can show them. But if we're going to teach something, we're going to teach progressive muscle relaxation, 10 soldier loose noodle, we need to be able to get up. That keeps them engaged and really demonstrates what we're talking about. And working with adults as well. Just get them to get up if they're starting to look really tense or even hypo-aroused, get them up, get them moving that body. Also lets you see the rest of the body. So you can see if they're shaking or if they're bouncing their legs a lot, or they got their arms crossed like this, but they might only have their head showing and you don't know how tightly closed off they are. That would be good to know in your office, right? We would notice if somebody really did this, but we might not on camera unless we have them stand up. We want normalcy. And then we also have to be prepared to answer questions. What was that noise? That was my dog barking. What was she barking at? Herself, probably in the glass door. That's what it mostly always is. Or the neighbor kid is in the yard playing, but she really wants to kill him, which would involve licking him to death. So they're going to ask questions. Some kids, especially our kids, are going to ask questions. Some adults as well. Who's at your house right now? You don't have to answer that. You can say it's just me and you in this room. That's all we need to know is it's just me and you in this room. Can I see your house? Can I go on a tour? No, we're right here in the therapy room, even though we may ask them to take us on a tour of their house. I don't really advise that. If they're office-based clients or school-based clients, you wouldn't see their house. So there's no reason to just because you can, unless there is a reason. So the other thing about that is really you want to have them have a stable place for their device. Any of you work with young kids and they've moved the phone all around and you've gotten dizzy because you're running through the house or you're doing this or they're saying, watch this. Are they doing this? You ever get that on a session? Yeah. 4-year-old? I have one boy who's 9 who was constantly, guess what I have in my hands? Guess what I have in my hands? I'm like, I don't care what you have in your hands. So we want the device in a stable place. One, that helps us not throw up or get a headache. But 2, it really says this is work. This is work. This is therapy. We're sitting right here or standing right here or doing something right here. Maybe you would walk with your kids sometimes and you might want to do a 10-minute walk with them. That could be okay if they held the phone steady. But it's worth it, but you need to talk to them and tell them. Again, we teach them how to be good telemental health clients. My lady I did the intake with yesterday took me inside. She went outside to throw something away. She came back in. She was up. She'd go say something to her kids. She'd come back. And I'm like, okay, here we go. This is going to be starting place number 1 on the next session. Starting place number 1. And she is anxious. She said she was anxious, but I just saw it happen. Woo, you do. You are easily distracted. So stable place for it. If you're working with somebody that's going to be moving around, set up the device, have the parent, caregiver, or the client tape off or mark in the room how much can be the therapy space, what can be seen. Does the camera need to be lower or higher? How much of the room can you see? And the kid has to stay in that amount, that space. They have to stay in that space. Nobody should be laying down in bed. That's not real conducive. We don't do Freudian work anymore. We don't lie down on couches. We want them up because we want them really engaged. We don't want them drifting off. So, any questions? Or what questions are out there? You can talk, you can unmute yourself, or you can type.
Hi. I have a question.
Uh-huh.
So say, for instance, we have a client that travels out of state and is going to be out of state for a while, and we're in Louisiana. How does that work with telehealth or telemental health? Are we able to, or do we have to like get licensed in that state that they're currently in for that time?
Yeah, it totally works, right? Because I'm talking to you guys in Louisiana, but I have to be licensed in the state where they're sitting to provide
Okay.
mental health services. And hopefully your agencies are really getting those policies and procedures in place. But if your client leaves the state, you can't do it. Like I'm licensed
Okay.
in Mississippi, and I have a couple of Mississippi clients, but I'm also licensed up here, so I have some clients up here. And I had a client who we were meeting, and she said, "No, I'm at my grandma's." And I said, "Well, where your grandma where?" Because I knew one of them was in Alabama. And she goes, "I'm at my grandma's in Alabama." And I'm like, "We're going to have to reschedule because I'm not licensed in Alabama. Not only would I not get reimbursed, but it's unethical to practice in a state we're not licensed in, right? Outside of our license."
Kelly, we've actually had clients that went to Texas, were right on the Texas border.
Mm-hmm.
My husband had one, and he had her drive over into Louisiana over the border, and
Yeah.
like we're covered that way.
Come to the first rest station.
Yep.
Yeah, and they have to tell you. And so something to think about is asking them, where are you? Are you at your house? Another thing when we think about emergencies, right? So if somebody is becoming dysregulated or somebody's making threats to harm themselves, we should have their physical address. We want to ensure they're at that house, but what is the physical address of where you are? What is the physical address there? And then we want to have at least one, better if we have two numbers of responsible adults who can get to that kid quickly. So if I'm meeting with my kid and they're in the game room, I want mom's number or dad's number, even though they're just down the hall in the living room. Because if I've got a kid in crisis and I say, take me to your mom and dad, it's not necessarily going to happen. Or I could text them, and we set all of this up ahead of time. This is what we're doing. This is why we're doing it. This is what we're doing. This is why we're doing it. But for emergency purposes, you want to have the physical address in case you have to call 911. You want to have contact. You want to have contact information for people who can physically get there. So made me think of that, Michelle. Adults, if they're fairly stable, you trust it, then they can drive to the rest station, but they do have to come back in the state you're in, or at least, no, they have to come back in the state you're in. So good questions there. Kids, we always want an adult to be able to get to them quickly. So that means, Mom, while I'm meeting with your kid, you can't run to the grocery store. What if there's only one device and the child is on it? That's a prickly pear, and it happens with some of them. And in that case, we would have to make a deal up front that if I say get your mom or get your dad, you will do it. We might have the number of a neighbor. I know they can't always come into the house. They can't always come in the house, but you might have somebody who could go over and knock on the door. So I would have two numbers in that case. That one and another one, if it were possible. We have to do the best we can. We know we don't have ideal circumstances, but do the best we can. Can you provide sessions via telephone? You can provide. I don't know if it's paid for. You would have to look at what's paid for, what's reimbursed and what's not reimbursed, or how you're going to get paid for it. You can't do some of the evidence-based models by telephone. You cannot do TFCBT by telephone. You don't want to do any kind of trauma exposure work by telephone. Parenting and CBT have research about use of telephone, using by telephone. have you done any group sessions? I have not done any group sessions. I haven't been brave enough to tackle that one yet. I don't run groups. I do a lot of phone call groups with clinicians, but I haven't done. Anybody out there that you've used it for group sessions so far? So, Rondalyn, we don't have an answer for you. Wait, Lisa said she has done it and it worked well. And Lisa, what kind of group and what age group was it? I know they're having a lot of luck with AA meetings and NA meetings online. So Lisa, what and where and how, I mean, what kind of group and what ages? Adult and adolescent substance abuse groups, also domestic nonviolence groups for adults. Cool. And Lashika has done it as well in drug court. Nice.
Kelly?
Yeah.
Yeah, I work for Florida parishes, and our clinicians are doing groups via telehealth.
Mhm.
They're doing the share screen, so we use modular-based system programs, and they're sharing screen and then go back and forth. One of the things I understand that LDH
You froze up on us.
did was to say, sorry, one of the things that LDH, they said that before a group session, we have to let them know that they're actually waiving their right to privacy, because we cannot guarantee in the group setting format that everyone's privacy and confidentiality is maintained. There's just no way to monitor that. And ensure that. So they have to agree to waive their right.
So you don't know if somebody's sitting in the room with somebody else.
Correct. So they have to agree to waive their right, and you have to document that they've waived the right. And if they don't want to, then you have to offer individual sessions.
Okay. And are you guys using DocuSign to have them sign a consent?
We're doing everything verbal consent at this point. And then once we get back into the clinic setting, then we'll go back and have signatures done.
Cool. Cool. So
And
it
this
sounds
is
like
Valerie. We do a lot of sessions by telephone, but in our notes, we have to document the number, consent for doing it by phone, and all that. That has to be documented, that they gave consent to do it via phone with the phone number.
okay. We got a
Are
lot
y'all
of
being
creativity
reimbursed?
happening. Go ahead.
Are y'all being reimbursed for the phone sessions?
Yes, we are.
Thank you.
Yeah, right now things are pretty lax. So, you know, like we got to get to our clients however we can, and trying to keep mental health centers and other agencies up and running. How can we fund them? If the only way you can get to your client is by phone. So there's been a lot of allowances, and I don't know how much of that'll stay afterwards. I hope a lot does. Make mental health services a lot more accessible. But I'm not sure how much will stay. I know that everything's up in the air right now. Good questions. So another little pandemic joke. When you first started your job versus your job right now. If we're at home, we have to stay professional. You can work at home, but you can't be at home and work. All right, guys, that's all I have. Got a couple more minutes for questions if anybody wants to ask anything. Otherwise, thank you very much for joining me. I hope you have a great weekend and you get some rest.
Thanks.
And
I have a question about the slides. Will it be sent to our email, or do we need to provide it in here in the chat?
I don't know how to.
If you send me the PDF of the slides, I will send it to everyone in the follow-up email with the CEU certificate. And
Okay.
I will also send a link for the other webinars coming up. And if you're interested in the consultation calls for any of the EBPs to get more technical support around doing EBPs over telehealth platforms. So thank you so much, everyone. And thank you, Kelly. This was excellent.
All righty,
Yes,
guys.
thank you guys.
Be be real down south. I'm trying to get there. Trying to get there.